So, the opioid crisis. It's entered a new and, frankly, a much deadlier phase. We're not just talking about prescription pills or heroin anymore. There's this wave of incredibly potent synthetic opioids that has completely changed the landscape, and it's overwhelming our emergency rooms. It really demands a whole new level of understanding. Okay, so let's dive into the clinical reality of this crisis, the science behind opioid use disorder, and the treatments that are out there reversing overdoses and saving lives. To really get a handle on the scale of this, just start with this one number. Over 76,000 overdose deaths in the US in 2022 were from synthetic opioids. And the main driver here is fentanyl, a substance so powerful it can stop someone's breathing in minutes. This isn't just a small increase. It's a fundamental shift in the threat that we're all facing. And this chart, wow, it just lays that shift bare. I mean, just a few years back, heroin was a major cause of fatal overdoses. Fast forward to 2022, and it's been completely dwarfed by synthetics. And what makes this even worse, a lot of standard hospital urine drug screens, the ones that test for opiates, they don't even pick up fentanyl. It's like an invisible killer that needs specific, targeted testing to even find it. Okay, so to really understand why these drugs are so dangerous and, just as importantly, how our treatments work, we've got to look at the pharmacology. The whole story of opioid effects, overdose, and reversal, it all happens at one very specific target in the brain. Getting a grip on this mechanism is absolutely key to everything else we're going to talk about. It all boils down to this guy right here, the mu opioid receptor. The easiest way to think about it is as a very specific docking station on our nerve cells. When an opioid molecule comes along and binds to it, it sets off the effects we all associate with these drugs: pain relief, a sense of euphoria, but most critically, it sends a signal to the brainstem to slow down breathing. This is the direct cause of an overdose death. So here's the crucial idea. You can think of this whole interaction like a lock and a key. Every single opioid molecule, it doesn't matter if it came from a plant or a lab, is basically a chemical key floating around in the body. And it's on a mission, searching for the one specific lock that it was made to fit. And when that key finds the mu receptor lock and slips inside, it turns and boom, it unlocks this whole cascade of effects. Now, with these super potent synthetics like fentanyl, this happens with incredible speed and force, leading almost immediately to profound respiratory depression. That just means breathing slows down to a dead stop. This right here is the absolute core of acute opioid toxicity. Now, an overdose is obviously an acute medical emergency, but it's very often the end result of a chronic underlying medical condition. And that condition is called opioid use disorder, or OUD. So let's shift gears a bit, from the single event of an overdose to understanding the changes in the brain that drive that repeated use. This is the official clinical definition, and it is so important to understand that OUD is not a moral feeling. It's not a choice. It is a recognized medical diagnosis, a chronic disease of the brain that's defined by this compulsive pattern of use, even when faced with catastrophic consequences. Thinking about it in this medical framework is absolutely essential if we're going to provide effective treatment. So what does that pattern actually look like? Well, clinically, we diagnose it based on features like these: a persistent desire or maybe unsuccessful attempts to cut down, really intense cravings, and developing tolerance, which just means you need more and more of the drug to get the same effect. It also includes going through a really painful physical withdrawal when the drug is stopped. Untreated OUD leads to just devastating health problems that go way beyond the risk of overdose. For people who inject drugs, using non-sterile equipment creates a direct pipeline for bloodborne pathogens. This leads to really high rates of HIV, hepatitis C, and some very dangerous bacterial infections of the skin and blood. And to get more specific, bacteria that gets injected into the bloodstream can travel straight to the heart and start growing on the heart valves. This causes a really life-threatening infection called endocarditis, which can literally destroy the valve and mean a patient needs emergency open heart surgery to survive. And the damage just keeps piling on. Research is now showing that heroin use itself is linked to liver fibrosis, that's scarring of the liver, and this is independent of other causes like Hep C. A really dangerous, more recent development is the contamination of the drug supply with something called xylazine. It's a veterinary sedative, and it causes these horrific skin ulcers and tissue death. And because it's not an opioid, our typical overdose treatments don't reverse its sedative effects. But look, this is not a hopeless situation. Not at all. We have powerful, evidence-based medical treatments that let us fight back on two fronts. First, by reversing a life-threatening overdose in the moment, and second, by providing that long-term stability for the chronic condition of OUD. Both of these strategies go right back to our lock and key analogy. So, opioid antagonists, like naloxone, are what we use for that emergency reversal. Naloxone is a competitive antagonist. It just has a stronger grip on the receptor, so it literally kicks the opioid key out of the lock and reverses that respiratory depression almost instantly. On the other side, we have agonists like methadone and buprenorphine for long-term treatment. They gently occupy the lock to get rid of cravings and withdrawal, which allows a person to stabilize their life. So, once a patient is stable after an acute overdose, the whole conversation shifts to long-term treatment. For agonist therapy, which is the most effective approach we have for moderate to severe OUD, the big clinical question often boils down to this: which medication is the right choice, buprenorphine or methadone? This table really lays out the crucial trade-offs. Methadone, on one hand, often shows higher rates of keeping people in treatment, and it might be more effective for severe fentanyl use. The big drawback, though, is that it requires daily visits to a specialized clinic. Then you have buprenorphine. It has a much better safety profile with a way lower overdose risk, it doesn't have dangerous cardiac effects, and it's far more accessible since it can be prescribed right out of a primary care office. Okay, so after looking at this problem from the ER all the way to the clinic, what are the absolute most critical points to walk away with? Let's just summarize the bottom line on how we really need to view and treat opioid use disorder and acute intoxication. First things first, we have to manage OUD as a chronic illness. Just like we manage diabetes or hypertension, it is not an acute problem you can solve with a short-term detox. It is a brain disease that requires long-term, sustained medical care, period. This right here is maybe the most important clinical outcome of all. These medications are not substituting one drug for another. The evidence is absolutely overwhelming. Being in treatment with an opioid agonist like methadone or buprenorphine literally cuts a person's risk of dying from any cause in half. These are life-saving medicine. And finally, there is no single best treatment. There just isn't. Effective care requires a real partnership between the clinician and the patient. It's all about weighing the pros and cons of every option to find that individualized path that gives someone the best shot at long-term health and recovery. So we'll leave you with this to think about. We've established that OUD is a defined medical condition rooted in neurobiology, and we know that we have highly effective, life-saving treatments for both the immediate overdose and the chronic disease itself. So why do all these social and structural barriers keep preventing people from getting the care they need? Why does this stigma still persist?